Hello, and welcome to today's RevCycleIntelligence.com presentation brought to you by Optum. Proactive Denial Management Best Practices, Techniques to Get Claims Paid. I'm Kyle Murphy, Director of Editorial at Xtelligent Media and moderator of today's presentation. We will begin with a presentation by our speaker and conclude with a question and answer segment. Audience members are encouraged to submit questions at any time during the presentation using the Q&A tool to the right of their screens. For all technical matters or difficulties, click the Help icon at the bottom of the screen. Lastly, a reminder that a copy of today's materials and a recording of the webcast will be made available following this presentation. Before we begin, I would like to take a moment to thank our sponsor, Optum. Optum delivers solutions that help navigate the journey from providing care to managing health. We offer revenue cycle management expertise, services, and technology to help you achieve your most vital financial performance goals. More specifically, our claims and clearinghouses solutions allow physician practices and hospitals to submit clean claims, reduce denials, and increase the first-pass payment rates while streamlining workflows for optimal reimbursement. For more information, visit www.optum.com. Now on to our speaker. Elizabeth Woodcock is principal of Woodcock & Associates and is a professional speaker, trainer, and author specializing in medical practice management. Elizabeth has focused on medical practice operations for more than 20 years. Combining innovation analysis to teach practice operations, she has delivered presentations at regional and national conferences to more than 200,000 physicians and managers. In addition to her popular email newsletters, she has authored 15 best-selling practice management books and published dozens of articles in national healthcare management journals. With that, I would like to welcome Elizabeth to begin today's presentation.
Thank you so much, Kyle, and thank you to our sponsor today, Optum. Most of all, thank you to all of you for giving us your time today to learn more about proactive denial management best practices. We're going to talk about techniques to get your claims paid, what you deserve. Our call to action today is fairly strong. Part of it is because we're staring in the face of just a few more months of a basic, a simplified diagnosis coding system. And yet on October 1st, 2015, projections already in for a doubling, again, 2 times denial rates based on the impact of ICD-10. So we're going from 4, 5, 6% industry norms, depending on your specialty, to 8, 9, 10, perhaps even as high as 12%. Particularly those of you in specialties like orthopedics, where the complexity of ICD-10 is almost mind-boggling. Indeed, regardless of this challenge, denials at any time, whether it's pre-October 1st or post, cost us a lot of money. In my research, every single time a claim is denied, it costs you $15. Now you might say $15, I mean really, that's nothing, but consider 2 important tactics. Number one, that $15 is not once a day. Oh no, it's 2, 3, 4, 5, dozens of times a day, and that money truly adds up. Furthermore, the $15 is a drop in the bucket compared to the denials that turn into write-offs. So those that cannot be reversed for payment and indeed must be written off altogether. Hey, $15 is nowhere near the hundreds, if not thousands of dollars in bad debt that are written off because we are not effectively working, pursuing those denials until the claim gets paid. So enough of the call to action. You're all seasoned professionals seeing this each and every day. Let's take a look at the basics. The basics. A lot of folks ask me, Elizabeth, why are my claims getting denied? And folks, I have to ask you right back, because you're sitting on the business intelligence in your practice management system to answer that question yourself. So once a claim goes through the payers, 8, 9, 10 edits, and finally hits up against one of those edits, doesn't get paid, it gets returned to you. We normally refer to that as post-adjudication. You get the denial back. Well, that denial is a term that means a group code is posted on your remit or paper EOB. This signals to you, hey, you're going to have to live with this denial yourself. It is a CO, a contractual obligation. You are not allowed to flip this to balance bill the patient, or that denial will indicate, oh, no worries. This moves on to patient financial responsibility, and in that case, go ahead and flip it over to the statement process. Either way, when we get those group codes, they are accompanied by a SARC, a claim adjustment reason code. That reason code giving us a further indication of why that claim was denied. We may also get a remark code, a remittance advice remark code that further describes that denial. Indeed, and every biller should have a list of both sets of codes. These were standardized for the industry a number of years ago associated with HIPAA. So those entities that are HIPAA covered must utilize these coding systems, and you can find those and print those out at the Washington Publishing Company. I've given you the direct link to those reference lists. Again, a great idea for every biller to have those. So now we know why that claim was denied, and that's really the operative term. Why? I think we next break the denials into two different categories. One, like PR1, the deductible amount. Hey, that's easy. I'm not even really sure if you call that technically a denial. I like to refer to it as a soft denial because it gets routed then directly into our statement process, not even requiring any manual intervention ideally. I love to put to those PRs, unless there's some challenges associated with them, to route them right into that statement cycle, right into that process for patient collections. But then we have our hard denials, like CO. Aha! Remember, that's contractual obligation. I can't just press this onto the patient. CO15. Uh-oh. I've got an authorization number that's missing, invalid, or does not apply to the billed services or provider. Now, in yesteryear, do you remember when we were working denials and we had that, oh my gosh, that red stamp pad and the stamp that said appeal? And we used to, boom, put it in our red stamp pad. We'd print off our HCFA 1500 and we'd stamp appeal on that and we'd send it back through the mail. Folks, that does you no good. What we need to do with those CO15s and other denials is figure out a way to really route that work effectively, appropriately within our business office in order to get that claim paid. We do have some challenges. I mentioned that there were these standardized code sets, the RARCs and the SARCs. Unfortunately, even though the code sets are standard, our payers use them inconsistently. Furthermore, particularly with regard to the remark codes, there are some incredible complexities associated with the code sets. So even if we could figure out a way to automate the entire thing, we still unfortunately need some manual intervention based on these facts. That does not, however, mean that we look at these denials, we say to ourselves, well, oh my goodness gracious, our business office routes those denials to billers and they get it done. Okay, let me step back and understand. They get it done? Okay, what exactly does that mean? And you say, oh, Elizabeth, I mean, Sally knows, Susie knows, she knows how to work those claims. Unfortunately, even though we've got some great Sallys and Susies just routing them out to our billers blindly, is not a strategy. Partially because if we route all of these to our team members without any effective strategy, we cannot indeed instill what is perhaps the most important term that we can relate about denial management, which is accountability. And why can't we? We don't know who's getting the denials. We don't know how Sally and Susie work. Sally and Susie don't even know how they're supposed to work because they just learned from Mary and Joe who were in the seats before them. Oh my gosh, we have really got to figure out how to put some more robust protocols behind our denial management process as it relates to staffing. So where to start? In my opinion, we've got to really root out the professional highlighters. Oh, you might be saying, what, professional highlighters? Well, y'all, I met my first professional highlighter about 20 years ago in a lovely pulmonology office. These were the days where we still had ironing boards because all the face sheets came in, stuffed down in the pulmonologist's pockets, and we had the ironing board that would iron the pieces of paper out. Oh my gosh, insanity. So I sat down with this lovely employee and I said, oh my gosh, tell me what you do every day. Lovely employee. Let's indeed call her Linda. So Linda looks up at me and said, oh, Elizabeth, well, the first thing I do every morning is I print off my report. Okay, she's in charge of account follow-up, working denials, pretty much everything related to getting claims paid. So Linda sits down and she prints off her report. And y'all, I'm absolutely amazed those reports are never less than 3 inches thick. I don't care. We have multi-million-dollar systems, and there they are, 3 inches thick. 3 inches thick. Then she pulls out her highlighters. And y'all, I'm telling you, her husband had actually made a custom case. The highlighters had little holes in them. There were 12 different colors. And of course, what did she do? She got the blue for Blue Cross Blue Shield, yellow for workers' comp, green for Medicaid, and she began to highlight the 3-inch report. There it was, my professional highlighter. And then she whips out a ruler. Every time the rulers start getting involved, I really start to get scared. The ruler comes out because what she wants to do is indeed highlight, underline all of those accounts that are high dollar. In her case, it was $1,000 and above. And then she whips out another pen and she starts putting asterisks next to some of them. I mean, there was a whole methodology. After I got finished with lovely Linda, I said to her supervisor, when does Linda start to work every day? And she said, oh, Elizabeth, about 2:30 in the afternoon, and she does get off at 3:30. Oh, my goodness gracious. So our professional highlighters, we have many of them who work in the business office. I think we need to instill some accountability. I like to put time frames. You may not agree with these. If you don't, that's fine. But place some expectations in writing as we begin to really gear up for our denial management process. The first is when to touch denials. I think it's 72 business hours. 3 business days, I got to touch them. I got to get those denials touched. What happens if you don't? Oh, my gosh. Have y'all looked in your drawers lately? Again, multi-million-dollar systems, and I'm still opening drawers. And by the way, our professional highlighters have different colors of folders. Oh, the reds are my commercial denials, and the blue, of course, that's Blue Cross Blue Shield, and the yellow's workers' comp. Oh, my goodness gracious. 72 hours, I've got to have those denials touched. Or whatever you set in terms of a time frame. Second written expectation is how much work should I get done every day. My range, if you will, is 50 to 70 daily per biller. Now, you can certainly see practices where 50, are you crazy? I'm a nephrology practice. I've got a month's worth of dialysis charges, 1 line item, 15 line items are denied. There's no way I can get to 70. Okay, I understand, but set some parameters based on what you realistically feel your employees can perform on a daily basis. This is absolutely critical from a management perspective based on the work coming in and the work going out. So let's take a look at this. We have indeed work cues. Hopefully you're using them within your practice management system. If not, you can certainly create them with paper, but it's ideal to have them completely automated so that as those hard denials are coming in, they get placed on your biller's work cues. And so what we want to do is ensure that the work that is coming in equals the work that is going out. As in this case, Billy the Biller is going to have a problem, and that problem is going to be a snowball before long. And y'all know better than me what happens when those denials pile up, and they pile up and up and up, and nobody can get to all of them. One of two things starts happening. Number one, you got to write stuff off. And that $15, again, is a drop in the bucket compared to the money you're losing. Number two, oh my gosh, the work starts to be hidden because you have the Sallys and the Susies of the world who are very proud of their performance. But folks, they can't handle it. If you have, for example, 500 denials being created every day, and you've got 5 employees, I think that's nearly impossible to avoid a gap in the work. So that gap then becomes larger and larger and larger, and the Sallys and Susies of the world, embarrassed about the gap, begin to hide the work. A year or two later, you find that work queue that never got worked. You find, oh my gosh, and seriously, I have found this, an entire room full of EOBs stacked up, thousands and thousands that nobody ever worked. And tremendous amount of write-offs can happen very, very quickly. So again, allow me to review. You want to set those expectations in writing about turnaround time and employee productivity on a daily basis. If you don't like those 72 hours and 50 to 70, fine, but set your own parameters. Furthermore, as the executive over this business office, you want to ensure that the parameters you set match the work coming in and the work going out. Otherwise, you're going to have a big challenge on your hands as that snowball gets larger and larger. So let's talk about tactics, best practices to manage those denials. The first is to figure out how you're going to map the work. The way I like to map the work is 3 individual work queues. This might represent 3 employees. It might represent 50 employees or even hundreds that are organized as such. Let's talk about our coders. Our coders then would get, of course, the SARCs and RARCs that are related to coding, bundling, medical necessity, modifiers, CCI edits, etc. So we're going to take those remark reason codes and we're going to route them into manually or ideally automatically the work files, the work queues of that coder or team of coders. Furthermore, we're going to take a look at our entry-level employees. I like to do this with denials because there are some basic denials that I really don't need a coder, and one would argue I really don't even need an experienced biller to handle. What am I talking about? Subscriber not eligible. Okay, folks, it doesn't take a rocket scientist, particularly when I have accountability. It doesn't take a rocket scientist to figure out what are the steps that are needed to follow up on subscriber not eligible. I would argue I do not need a coder. Furthermore, I don't even need an experienced biller to attack that denial. Other basic denials might include missing data. The NPI is missing. The NPI from the referring physician's missing, for example. So route what you feel comfortable with to those entry-level billers. It's a great stepping stone, if you will, in your business office from an HR perspective to really allow your billers to move up. Entry-level, experienced, and then once they are certified, the coders. What do we do with the experienced billers? This is where I normally find the majority of denials to fall, although of course it depends on your specialty. Those experienced billers are really performing that account follow-up. They're looking at the denials. One would argue they're also taking care of any open claims. Open claims, of course, are those that no one has paid and no one has denied. Those outstanding claims, not denied, not paid, are attacked by our experienced billers as well. I like to divide, depending on how many billers I have, these experienced staff members into payer-based teams, so that I would have a Medicare team, a Medicaid team, a workers' comp commercial. You may handle some other payers in which you have a large enough volume to create a separate biller and or team. If you do only have one biller assigned to that particular payer, please make sure you have cross coverage, because the worst you can do is make that assignment to one individual. That individual gets overwhelmed, goes on vacation for weeks or takes other leaves. You're going to be between a rock and a hard place. So again, take those denials, figure out how to map them. This is a strategy I like to deploy. Entry-level experienced billers and coders, you may have alternatives, but something you may want to consider. I've mentioned accountability several times, and again, most of our denial management strategy I find to be in our heads. And oh my gosh, the vast majority of the time our heads are awesome. But if you get a problem employee, that's where we get stuck. So take the time to think about the complexity of this process and the fact that there are no protocols in writing whatsoever to manage denials. Again, we just rely on our employees' heads. I think that is a huge problem, and it's one that's going to create and lead to even more significant challenges. Take the time to figure out how to develop a denial management guide. This is your action plan based on your commonly received denials. I think if you get 80%, and frankly, 80% is probably represented by no more than 30 different denial types. So our action plan, what do we do when we get a denial for registration related to an out-of-office facility service, including the hospital? Okay, I mean, it's really not rocket science, but I need the steps. And I need the time frame. What do? I verify online claim status. Then I take a look at my own internal records, my PM, my EHR system. All right, next I go to the hospital system. And please, y'all, don't just have one computer that everybody has to go wait in line to query the hospital system. Talk about inefficiency. Every one of your team members need access to all of the business intelligence related to your revenue cycle. Otherwise, your denial management strategy will be ineffective. We need a time frame. If you like the 72 hours, that's fine. Otherwise, put in a different time frame. And importantly, we need thresholds. Because I got to tell you, not only are billers commonly professional organizers, oh my gosh, they're also commonly individuals who will go to the nth degree to get everything paid, including a $1.50 charge. Okay, folks, we cannot use all of your time to pursue a $1.50 charge. Now, 10 years ago, 20 years ago, when we had more people than we knew what to do with, fine. But today, folks, oh my gosh, I haven't been in a business office for 5 years where there wasn't work sitting there waiting to be done because there's simply not enough people to do it. So we have got to focus on prioritization and then take those $1.50 denials and batch them together and bring them to the payer's attention if there are 30, 40, 50, or hundreds of these items, but certainly not working them one at a time. Put your denial management guide in writing. Once we have that guide in writing, we can really refocus on the accountability. It is awesome, the most awesome training manual you could possibly have in your business office. What else do we do in terms of best practices? These tactics include understanding every payer's appeals process. That includes particular forms, addresses to where the appeals should be sent, which vary quite often from the claims address. Let's absolutely make sure we understand the appeals process. Furthermore, let's don't reinvent the wheel every time. Focus on a library. And I'm not talking about a physical library. I'm talking about an electronic one on your intranet that has all of the appeal letters that you have developed. And oh my goodness, if we possibly can, let's get those letters to actually interface with our practice management system so that they can be auto-populated. Oh my gosh, what a huge time saver. Remember, this is no longer a rubber stamp. This is a debate. You're in a debate with that payer. You believe your claim should have been paid. Be professional. State your case. State the particulars of the case. And really, really focus on getting that denial overturned. Be sure in your appeal to request a review of the appeal by an expert in your specialty. This almost always cannot happen, and so indeed it gives you an entree to do a second level of an appeal with that payer. So it's a wise idea to always make that request. Once you follow up on the denial, focus on not only the initial denial, but ensure that you follow up to make sure the claim gets paid. So indeed, we want to make sure we talked about our work queues, that we address not only the volume, but how do we build the work queues. I think we need to create awareness about timely filing deadlines by payers. So we sort those queues, typically having our commercial payers with the lowest or least filing deadlines first, and then within that date range, sort them by dollar. Again, prioritization, perhaps the most important strategy for a business office executive to have, unless you can enjoy having too many billers than you actually have work for. I'm doubting many of you are in that situation. Please don't forget to carefully monitor not only the size but the date of that work queue. We don't want that snowball to build in your business office. So these were all great strategies, and I think we'll always have denials. Our payers are one step ahead of us. Remember, they indeed have an economic incentive to deny our claims. However, perhaps our greatest, most important strategy of all is not to manage the denials, but to prevent them from happening altogether. So let's attack the problem. First, we need to go back to our basics. We talked about those group codes, the SARCs and the RARCs. Our denial data can lead us to a root cause analysis. We've got to figure out why our claims are getting denied. I think a great strategy is to go to those team members who are managing those denials, taking action on them, and sitting down with each one of them and saying, all right, Linda, Joe, Sally, etc., what denials are you seeing at your workstation over and over and over and over again? And you know what's amazing? When you ask that question, as I have done many, many times, oh my gosh, Joe, Jill, they are so excited to tell you. Why are they excited to tell you? Because they see the same problems happening over and over again. And if somebody can keep calm and prevent the denials, wow, would it make their workflow more effective? So what do we want to do? We actually want to take that intelligence and build in, ideally, automated processes to do one of two things as we are submitting the charges. One of those two things is either give us an alert. Okay, you don't have to stop us, but give us an alert that something is wrong. Furthermore, we may have to halt our workflow altogether and say, you know what, don't even go any further. A fatal edit, a stop, halt, you can't go any further because this claim, when it becomes a claim, will be denied. These are subscriber eligibility, pre-authorization is required, and it's not there. Folks, don't go any further because once the payer gets a hold of it, you aren't going to get your money. So let's build in these edits, these alerts, these stops on a pre-adjudication basis, ideally when the charge is being submitted, because that's our opportunity to run with these edits, these alerts, these stoppages, because we're right there in the moment. And we can fix the denial before it ever happens. So let's give some examples. By far the most common denial for a medical practice is that which is related to registration. Now that's a relatively broad term, but from that perspective, I mean it's a coverage benefits eligibility issue, or indeed we have the wrong data about the patient. During the registration process, we want to ensure that we verify coverage, that we check eligibility, and that indeed, going one step further, particularly because of all of the consumer-directed healthcare products, that we determine what the patient's financial responsibility is. And so I know many of you are like, check. I mean, Elizabeth, we've been doing this for years. Okay, I understand. What I am finding time and time again is that we have the process in place to run the coverage, to verify the eligibility, but very importantly, we do not have the workflow in place to take actions on the exceptions. We've checked off all the box that the eligibility check is run, but the information is still flowing through to our business office as incorrect. So please don't only have the financial clearance process as part of your workflow, but have protocols to take action on those exceptions during the point of the scheduling call, during the point of the patient's arrival at the practice. Any one of those actions can be taken when I have the patient face-to-face. When I get on the back end, all bets are off. The business office, it costs you so much to follow up on these denials because it requires our getting in touch with the patient, which doesn't happen overnight, and then working through the details over and over again. And I know you might be saying, whoa, we were talking about denials. We're not talking about billers now? What does this mean? So I think the most important takeaway from our webinar today is the fact that there really is no business office. In fact, every employee of your practice is indeed a member of your business office. Oh my gosh, our front office is, I like to call them not receptionists, not even schedulers, but directors of denial prevention. If we can embed a workflow that absolutely alerts us or even stops us from creating problems, we don't even have to mess with all of the people and the resources that we need in the business office to fix those problems, to work those denials, and to eventually get paid. Now, we talked a little bit about coding-related denials. We want to ensure that same workflow, embedding the stops, the alerts, the edits, as those problems are being made. We want to identify them first. We indeed want to do the same for any coding-related denials. At the very least, as we're entering CPT, ICD-9, and soon to be ICD-10 codes, we have some basic edits built into our charge submission system. That workflow might be purely manual, or ideally it is fully automated. We take the nuances of coding, the AMAs, the American Medical Associations, the World Health Organization's diagnosis, and we build in the problems, the alerts for the problems, as we're keying in the codes. From an advanced perspective, we take not only sort of a white label, if you will, coding edits, but we actually advance those edits, and we integrate payers' payment policies. We take a look at Medicare's LCD and NCD national and local coverage determinations, and we embed the reimbursement guidelines for our commercial payers. These change, folks, on an almost daily basis. So again, if we have a manual system, we need to ensure that we're updating it over and over again. Let's use our team. Remember our billers, our advanced, our expert billers, our coders. Let's use our team very much in synergy with one another to really, really focus on these edits. Again, our opportunity is to prevent, not just manage, the denial. And then, wow, the future, the stratosphere, if we can get there, is opportunities before the service is even rendered. Let me give you an example. When you order, for example, an MRI, you have a patient who has a diagnosis of low back pain. Okay, that MRI is being ordered. I've got the ICD-9 code to indicate low back pain. Folks, what's going to happen? All of us in the billing world know that that claim is not going to be paid. And so if we can embed these alerts even at the ordering process, wow, we've certainly taken our denial prevention strategy surely to the next level. So this requires, whether these edits are manual or ideally automated, it really requires an incredible strategy that's very different than it was historically related to the revenue cycle. And it goes back to the comments that I made about every employee being a member of the business office. We have to figure out, all right, if we're going to prevent denials at the charge submission, at the submission of registration, then I need to have my directors of denial prevention employed at my practice. I need them to be my checkout team. I need them to be those coders and or employees who finalize charges at the practice site. If they just skip over the edits, folks, why even have them? Why even have them? I like to have a service agreement, a compact, if you will, that describes the responsibilities of the practice site or sites versus the business office. And this, I believe, is very vital. Once we really put into place this denial prevention strategy, because if I don't have some accountability at the practice site, I've made an investment into a strategy that will not garner a positive return. Now, you might say, well, gosh, Elizabeth, to get all these edits perfect, particularly when you talk about payer policies and commercial reimbursement, commercial payers, reimbursement guidelines, really, this is not going to work. Well, it's important to recognize that as we really focus on our denial prevention strategy, we are going to make mistakes. There are going to be edits that tomorrow aren't going to be valid. Next Monday, they're going to change. And that's the dynamic nature of the revenue cycle for professional fee services. Otherwise, we wouldn't need a business office, right? The doctor could just throw in a code and the doctor would get paid. We are the complexity. We are the complexity of the revenue cycle. And in that complexity, as we make changes, there are going to be mistakes that are made. And that's okay. In fact, embrace the mistakes because they indeed are proof that we are trying. So what we've done is really focused on two aspects of denials and those techniques to get our claims paid. The first is really to address the management of denials. And if you recall, we discussed indeed how to identify those denials and really focused on the accountability, the denial management guide, for example, how to really think about our work cues to ensure that we're avoiding that snowball effect, and then very specific best practices with regard to managing denials. And then we turned our attention, we pivoted to really where the real opportunity is, and that is in attacking the problem, preventing the denial from happening altogether. Our goal, of course, is to reduce the size of the business office, or at least those denials that are coming in, so we really can get all of the work done, because there's more work to do than we have folks to do it, team members to do it, by preventing those denials. And we even took a look at very specific strategies about preventing those denials, including ensuring that we have that compact or service agreement with our practice sites. So I hope that you've gotten a positive return on the investment of your time. I'd like to now turn it over to our moderator. Kyle, can you go ahead and proceed with our webinar?
Thank you, Elizabeth. Before we move on to the question and answer portion of our webcast, we'll now have a word from Steve Sewell, Solution Engineer at Optum.
Hey, thanks, Kyle, and thank you, Elizabeth, as well. Always such a dynamic presentation and the wealth of information that you're able to provide on all of these topics. And to everyone on the phone, I'm excited to have an opportunity to tell everyone today about Optum and the work we're doing with partners across the health system to really power modern healthcare. Optum was established back in 2011 as a company focused on solving the most complex challenges facing healthcare. Today, we are now 80,000 people strong worldwide working with the same mission. And our mission is a bold one. Our mission is helping to make the health system better for everyone. And because we uniquely serve the needs of all participants across healthcare from the center of the system, we are able to better connect them with a shared focus on creating a healthier world. And as I think back to all of the scenarios covered today, the problem of denials is one that we have talked about for years. It's difficult, if not impossible, to stay on top of changing regulatory and payer reimbursement requirements without devoting, as Elizabeth mentioned, a large amount of staff to manage the process. It's simply not cost effective. Preventing a denial before it happens is truly the best way to start eliminating denials. That is the answer to that age-old question of what to really do with denials. And if I would ask you to sit back and imagine for a second, imagine how your practice would benefit from technology and automation focused on denial prevention rather than denial management, and how that could be leveraged with connectivity to all payers, creating really a full life cycle of a claim from, as Elizabeth quoted, our directors of denial prevention way up in the front in patient access, all the way to the backside where we're ready to send out statements to our patients for those deductibles or copays they may owe. If you look at the automation that can be delivered, things start to go down. Your denials and even rejection rates start to decrease. And when that happens, your AR days, they get lower. And when that happens, cash flow would improve. And that makes everyone happy because ultimately that's what we're trying to solve for with our organizations, is improving that cash flow, because every day our clinicians are out there with patients doing the best work in the world at making them healthier. And let's make sure that we're able to be financially responsible and keep those organizations open and expanding so they can have the opportunity to have more contact with patients who need care. Again, the answer is clear on how to best handle denials. Prevent them from happening, period. Our approach at Optum is to leverage technology and automation that does just that. Whether we are reducing those denials by pre-screening for those billing or even coding errors, but take that one step further. Let's look for unidentified revenue or missed revenue that's not currently being billed for that should be billed for. When Elizabeth spoke earlier about regulations and guidelines changing even on a daily basis with payers, we know that what happened yesterday is definitely not what is going to happen tomorrow. So being able to leverage both pieces of technology and automation to prevent the denial and to find that missed revenue ultimately goes back to what we wanted to instill with everyone, is improving that cash flow, expanding our clinicians' presence with patients. And Optum does that by staying current with all new and even changing billing guidelines. And that allows you to comply more easily with both Medicare and Medicaid and each of your commercial payers. By leveraging all of those things, again, you start to realize that significant ROI by that denial curve dropping down, that cash flow increasing. And we often laugh because we can't get any work done because we've got so many projects going on. If there is that 3-inch stack of paper and a highlighter, let's find out how we can get that so we can really get the work done that our organizations need. Again, I wanted to thank everyone for attending today. Big thanks to Elizabeth for her participation, always learning something new every time we hear her speak. And at this time, I'll pass it back to our moderator, Kyle, as well. Kyle, thank you.
Thanks, Steve. And now we're going to move on to our Q&A session. Once again, audience members are encouraged to submit their questions. We already have one here to kick things off. So this one is for you, Elizabeth. We have recently been hit by a rash of denials and delays from payers requesting, 1, a copy of medical records, and 2, itemized statements. All of our claims are electronically transmitted, so these types of requests really slow down reimbursement. Do you have any ideas for managing this?
It is a great question and something I'm seeing particularly related to Medicare Advantage plans. And let me back up and tell you why. The reason is that from a payer perspective, these plans quite often are paid more from the perspective of the government for managing patients with higher clinical acuity. So what these payers want to do, of course, is get the actual records so that they can prove that acuity. So a couple of comments about that, in addition to the fact that, as I just said, I'm hearing and seeing that from practices across the country. So the first thing is, I think ICD-10, ironically, will actually help us from this perspective because the more sophisticated we can be in terms of diagnosis coding, that will actually help the payers avoid having to review those medical records themselves to determine that acuity level. So we might actually see a drop-off post-October 1st. I'm keeping my fingers crossed, certainly. Secondarily, the question then becomes, from a contract management perspective, can you indeed negotiate a better workflow from these payers with which you are handling these requests? So you can either negotiate a certain portion of the records, not every claim, but what percentage of the claims are they allowed to request, or indeed a cost of actually retrieving and producing the records that could be absorbed by the health plan on a fee-for-service, if you will, a per-unit basis, or, hey, this is our opportunity. If you want us to do this additional work in order to get this claims paid, then maybe we are here to negotiate a higher rate for that service. So again, giving you some options, but certainly we're seeing a lot more of these, hoping against hope that we'll see a reduction come post-ICD-10. Kyle?
All right, next question. So we bill for a facility that is out of network with all providers. Can you think of an effective way to manage and prevent denials or underpayments?
Well, for out-of-network billing, that is, going into a different stratosphere. Indeed, if we have edits that we can put in place to identify challenges on the front end, as we have discussed during the webinar, that would be wonderful. Short of that, I think particularly for out-of-network billing, and it sounds like for this facility, you're always out-of-network, it's really to focus on patient financial accountability and understanding to the health plan level, not just the insurer level, but to the health plan level, what out-of-network benefits that patient has and pursuing those immediately. So I'd really think about the front end as we discuss that director of denial prevention, particularly if you're in that out-of-network issue. Kyle?
Next, I have an employee who can't seem to touch more than 20 accounts each day. What can I do in that case? Well,
first of all, you could take away all their highlighters. No, I'm just joking. But indeed, really identifying, and I think this is important because we do have a lot of techniques in terms of how we work that have that tendency to be that professional highlighter. And so I think every single staff meeting should have at least one idea to work smarter, not harder. Here are some things that I try to do, and I think a great biller should do as well. Do not batch work. I actually literally have on my workstation the Nike swoosh, the Just Do It, because that's what we want to focus on. Get it done and get it done now. Otherwise, the work takes longer and longer and longer. Make sure you know every single hotkey, macro, template, shortcut, etc. in your system. Oh, that would be a great idea for the staff meeting, is that every single staff meeting there's just one system tip. And I bet some of your employees know it, but let's make sure we share in those best practices. Banning voicemail, just completely getting rid of it. Hello. No, in all seriousness, voicemail is incredibly inefficient because it requires us inherently to batch work. And then I think really, especially if we're not effectively using those work queues, is to figure out some sort of online tickler system or a system that's embedded within our practice management system to really nudge us, to tickle us on all those follow-up actions, when to strategize about particular accounts. It's very, very difficult to manage hundreds, if not thousands, of accounts at the same time without some more effective automated techniques to help you get there. So those are just some strategies, but probably should begin with getting rid of the highlighters. Kyle?
Next question. As a manager, how should I monitor denials?
Well, we talked about some of those details in the webinar, the work queues, for example, but we need to not only manage those work queues, we want to ensure that all of those denials are getting routed to them. And by doing that, I'd want to match up those work queues and also be looking at my key performance indicators, my KPIs for receivables management, things like my days in AR, for example, my net adjusted collection rate as another example. And I'd really want to focus on making sure that I don't get any write-offs based on denials. That is really the key. There's always going to be a cost to working them. I define that as about $15. But it's critical to avoid the write-offs and ensure that your employees don't bury that as some, contractual adjustment. For example, we've got to make sure we work those denials in a timely manner. We get those reversed because we want to get paid for what our physicians deserve. Kyle?
Awesome. And now on to our last question. Our big issue is registration at the hospital. How can I possibly fix that?
This is quite a common problem for medical practices because you're normally controlling the professional registration but have a hard time with the facility registration that happens in patient access, admissions, etc. So I think it's a good strategy because our hospitals want to be collaborators with physicians, is to actually present the denial data to the hospital administration. If that doesn't get you anywhere, then network with the other practices that work out of that hospital. Because I will tell you, if you're having problems, they're all having problems too. And then you leverage yourself as a group, even if you're not an integrated entity. You leverage yourself as a group of stakeholders in terms of focusing on preventing those denials, those errors, and guess what? It's also happening to the hospital too. So if you can get the attention of administration, folks, you really can move that needle with some good data, and it normally is a win-win for the hospital as well. Kyle?
That concludes today's presentation. We would like to thank Elizabeth, Steve, our audience, and of course our sponsor, Optum. And a reminder, for the latest news and information in revenue cycle management, visit RevCycleIntelligence.com. Thank you, and have a good day.